All right, if you're in medicine, it's not if, but when you're going to face a patient with a crazy low calcium level. And understanding hypoparathyroidism, well, it's not just for exams. It's a critical skill you need to handle these really dangerous situations. So in this breakdown, we're going to get right into what you absolutely have to know.
Okay, let's put you in the hot seat. You get that dreaded call from the lab. Your post-op patient's calcium is 7.1. And now they're telling you they have this weird tingling around their mouth. What's your next move? Right? This isn't just some number on a screen, it's a ticking clock. And our goal here is to give you the mental framework to know exactly what to do next.
So before we dive into what goes wrong, we've got to understand how it's supposed to work. I mean, it's actually pretty amazing. Your body keeps calcium in this super tight range. It's this delicate balancing act, and there's really one main player pulling all the strings. And here it is, the star of our show, parathyroid hormone, or PTH. Think of it as the body's calcium thermostat. The second your blood calcium starts to drop, these little parathyroid glands just pump out PTH. And its job is super clear. Bring that calcium level back up. It basically sends out two urgent memos. One to the kidneys, saying, hey, stop peeing out calcium. And one to the bones, saying, I need to borrow some of that calcium you have stored away.
But PTH doesn't go it alone. It's got a crucial sidekick. It also tells the kidneys to flip the switch on vitamin D, turning it into its active form, which is called calcitriol. And what does calcitriol do? It heads straight for the gut and starts pulling in way more calcium from the food you're eating. It's this awesome, coordinated system, all working together to keep things stable.
Okay, so what happens when our star player just disappears? Well, that's exactly what hypoparathyroidism is. The master regulator is gone, and the whole system just starts to fall apart.
Now listen up, because if you're a trainee, this is the one you have to burn into your brain. The number one cause, the one you're going to see over and over again, is injury during neck surgery. A thyroidectomy or something similar, where the parathyroid glands get accidentally damaged or taken out. Yeah, there are other causes, and they're good to know for tests. But in the real world, it's almost always post-surgical.
And this table just lays it all out perfectly. With no PTH, all those urgent, get more calcium signals are just gone. The kidneys start wasting calcium, just letting it spill into the urine. Vitamin D activation grinds to a halt, so you're not absorbing calcium from your food. And the bones? They just lock down their calcium stores. It's this devastating triple whammy that makes the serum calcium level absolutely tank.
Okay, so we know why it's happening, but what does it actually look like in a patient? Well, when calcium gets low, it's like it messes with the electrical stability of your nerves. They become super irritable, almost twitchy, and that's why the signs and symptoms are so classic, and, honestly, why you have to spot them right away.
It usually starts with something kind of subtle. That weird tingling feeling around the mouth, we call it perioral numbness, that's a huge clue. From there, it can spread to tingling in the hands and feet, and then you start getting muscle cramps. And those classic textbook signs like the hand cramping up and a carpopedal spasm, that's just a more extreme version of that same nerve irritability. Oh, and you absolutely can't forget about the heart. A prolonged QT on the EKG is a massive red flag that things are getting serious.
And here's a super important clinical pearl. Please don't get a false sense of security just because your patient isn't complaining about tingling. This quote right here says it all. A patient can go from seeming okay to having a life-threatening laryngospasm or a full-blown seizure, completely skipping those early warning signs. And that's exactly what makes this condition so scary.
All right, so your clinical suspicion is high. You think you know what's going on. Now it's time to prove it. And the good news is, the workup is pretty straightforward as long as you're systematic about it.
Here you go, this is your 3-step game plan. Step 1, make sure the hypocalcemia is real. Remember, you have to correct the total calcium for the patient's albumin level. Step 2, check a PTH level. Now, think about it. If calcium is low, the body should be screaming for more by pumping out tons of PTH. So if the PTH is low or even just normal in the face of low calcium, that's completely inappropriate, and it basically confirms your diagnosis. But there's one more crucial step you can't skip.
And this is it. This is the classic pitfall that trips people up. Low magnesium. You see, low magnesium can basically put the parathyroid glands to sleep. They can't secrete PTH properly, so you end up with what we call a functional hypoparathyroidism. The glands are there, they're just stunned. And the best part? You can fix it. But if you don't think to check a magnesium level and give it back, you can throw all the calcium you want at the patient, and it's not going to fix the root cause. Okay, diagnosis confirmed. Now it's go time.
And when we think about treatment, we really have to split it into two different scenarios: the acute, hair-on-fire emergency and the long-term, chronic management plan.
All right, for the acute situation, we're talking a symptomatic patient or a calcium level that's really in the basement, say less than 7.5. This is a full-on medical emergency. We're talking IV calcium, ideally through a central line, and you better have that patient on a cardiac monitor. Now, for the chronic, long-term picture, things are different. We're using oral supplements, but here's the trick. We can't just give regular vitamin D. Remember, you need PTH to activate it, so we often have to give calcitriol, which is the already activated form.
Now, this is another huge management pearl. Your gut instinct might be to push that calcium right back up into the middle of the normal range, right? Wrong. We actually aim for the low end of normal. And you might be asking why. Well, think about it. Without PTH, the kidneys can't hold on to calcium. So if we push the blood level too high with supplements, all that extra calcium just gets dumped into the urine. That's called hypercalciuria. And over time, it's a recipe for kidney stones and even kidney failure. It's a really careful balancing act. Okay, let's boil this all down. If you walk away with just 4 things, let it be these. 1. The most common cause is neck surgery. 2. Severe hypocalcemia can kill a patient, and it can happen fast without the usual warning signs. 3. Always check a magnesium level, always. And 4. The long-term goal isn't perfect calcium, it's low normal calcium to save the kidneys. And that's our deep dive into hypoparathyroidism. You know, the real test isn't just knowing the stuff, it's using it. So next time you're taking care of that post-thyroidectomy patient, or really anyone with some weird vague cramping or tingling, hopefully this whole framework just clicks into place in your mind. So, what's that subtle sign you'll be on the lookout for now?